The third point is MGD is progressive. Unless the root cause that's causing it is ameliorated, it is progressive. So if an individual is on a computer 16 hours a day and they win the lottery and they go off to a nice humid area, that's a little bit different. It may resolve itself. But usually it's progressive, and usually it leads to this dry eye cascade. Now, the cascade involves severe consequences. And the cascade may take weeks, it may take months, it may take years. But it ends up always in a chronic dysfunction and a disease process. Now, today is Monday, Saturday and Sunday, I put this slide in because I put it in for two reasons. Some of you in the audience, and my way is being paid by Tier Science, which has LipiView, and you will want success with LipiView. And others of you just will treat dry eyes. And it doesn't matter whether you're treating dry eyes with LipiFlow or you're treating them any other way that you choose to treat them. But your success rate will depend upon the diagnosis and the root cause. And I will keep showing this slide over and over again after each one of the objectives to show you how our thinking will change. So right now, if we were to take a poll among individuals who have extensive dry eye experience, have treated at least 1,000 people with dry eye, and we say to them, what percentage of people can you significantly improve within 1 to 2 years? It will be somewhere between 10 and 20%. And the rest will say, there isn't much we can do for them. We treat them with whatever we can, whether it's antibiotics, whether it's systemic, whether it's topical, whether it's an immunomodulator such as Restasis. But our percentage of success is really low. But you have to answer all those questions, because what are we really treating? Well, let's look at this cascade itself. The first point in the cascade is obstruction. The gland begins to become obstructed. When it becomes obstructed, you have less lipid. When you have less lipid, evaporation increases, and that's the key. The lipid layer prevents evaporation. And then you have a decrease in aqueous layer thickness, and then you have an unstable tear film. So when I started to think this over 8 or 10 years ago, I came to the conclusion that this was the cause of inflammation. Inflammation was not the cause of the cascade. Inflammation is a sequela of many factors that are associated in this dry eye cascade. Now let's talk for a moment about what happens next after we come down to this point. We have an unstable tear film and symptoms start. Stop. Symptoms start. What are the symptoms? Let's experiment for a second. I'm going to ask all of you just to do this. I'm going to ask you to blink once, blink twice, and then ask you to stare. And the reason I'm going to ask you to stare is for you to tell me what you feel. So let's go. Blink once, blink twice, perfect. And now stare 1, stare 2, stare 3, stare 4, stare 5, stare 6, stare 7, stare 8, stare 9, stare 10. We have enough. We have people who broke. What did you feel?
I started to
Burn.
burn.
What did you feel?
Same thing,
Burn. Anyone else want to volunteer what you felt?
Blurriness.
Blurriness, okay? Because you saw the vision. Exactly. Anyone else? You got the two big ones, burning and blurring. Now, why do you burn? You burned after 5, 6 seconds. Why did you burn? You burned because you didn't have enough thickness of protective layer to prevent the corneal nociceptors from firing. And they can tell you if you're burning. So now, start thinking about that and thinking about how that relates. So now the symptoms start. So the burning is this side of the story. The other side is lubricity is compromised. So you have a dual mechanism now starting in dry eye that will start this cascade and start the problem. And then it goes on. And as it goes on, the visible changes you can see with the slit lamp, we can all see a red eye. We can all see blepharitis. We can see staining. We can see lid wiper epitheliopathy. We can see inflammatory signs. And we can see anatomical changes to the lid margins. And the liner marks we'll get into. That's probably the most important unknown factor in all of dry eye. So if you use confocal, you'd find that there's massive changes in the cornea, in the inflammatory cells, in fibrosis, in cells just dying, and we don't know they're dying. But unless you had confocal, you wouldn't see it. So that is a real problem. And we've been involved with that now for about 2.5 years with a collaboration with Dr. Hamrau at the Mass Eye and Infirmary. And I've learned so much about that and how it relates to what we see with the slit lamp that I can look with the slit lamp and understand what I will most of the time see with confocal. So what's the summary of MGD? It's prevalent, it's chronic, and it's progressive. Hard to believe, but that's the take-home point.